All right, we'll go ahead and begin. Welcome, everyone. My name is Kira Bradford, and I am co-PI and technical lead of the HEAL Data Stewardship Group. I want to thank you all for joining us today for the 5th installment in our Fresh Fair webinar series. Today's webinar is called Demystifying Data Sharing, and will focus on providing clarifications around sharing HEAL data. This webinar will consist of a brief presentation followed by a moderated panel discussion and then a live Q&A. If at any point you have a question, please feel free to use the Q&A box. We are joined today by 5 HEAL program staff members, Christine Colvis, Michael Oshinsky, Wendy Weber, Shelley Sue, and Jennifer Villani. I will now go through and introduce each of them individually. Dr. Christine Colvis is the director of NCAT's Office of Drug Development Partnership Programs. This office promotes innovations that improve the efficiency of the discovery and development of, or improve the quality or accessibility of, treatments for patients. Colvis leads programs ranging from very early preclinical discovery and exploration of new treatment modalities with the potential to expand the target landscape to the development of therapeutics through early stage clinical trials. She is the co-chair for the NIH HEAL Initiative and the NIH-wide preclinical and translational research and pain management team. She completed postdoctoral research at the National Eye Institute after receiving her doctorate in biochemistry and molecular biology from Oregon Health and Science University. Also with us today is Dr. Michael Oshinsky. He is the co-chair for the HEAL Pain Preclinical and Translational Work Group and the program director for pain and migraine at NINDS. He earned a PhD in neurobiology and behavior from Cornell University and was the director of preclinical research at the Jefferson Headache Center at Thomas Jefferson University before he came to NIH 7 years ago. Also with us on the call today is Dr. Wendy Weber. Dr. Weber is branch chief for the clinical research in complementary and integrative health branch in the Division of Extramural Research at the National Center for Complementary and Integrated Health. The clinical research branch is responsible for the oversight of all NCCIH-supported clinical trials to develop and test interventions. Dr. Weber's portfolio of projects that she oversees includes the HEAL Initiative program, Pragmatic and Implementation Studies for the Management of Pain, also known as PRISM, the Pragmatic Trials Collaboratory, and the NIH DoD VA Pain Management Collaboratory. Dr. Weber earned a Doctorate of Philosophy in Epidemiology and a Master of Public Health from the University of Washington. Also with us on the call today is Dr. Shelley Sue. Dr. Sue is a health scientist administrator at the National Institute on Drug Abuse. Dr. Sue manages a portfolio on implementation science, chronic pain, services for cannabis use disorders, and leads the translational efforts bridging neuroscience and sciences research. Dr. Sue received her PhD from the University of California, Santa Barbara, where she conducted research on the neurobiology of positive and aversive effects induced by drugs of abuse, the influence of extended access or escalation on cocaine-associated opponent process actions, and sex differences. And finally with us here today is Dr. Jennifer Villani. Dr. Villani is the Associate Director of the Healing Community Study. She comes to NIDA from the NIH Office of Disease Prevention, where she conducted a wide range of research activities to advance disease prevention. She developed and tested a new method for portfolio analysis that utilizes machine learning to characterize NIH prevention research in areas including substance use and health services. In addition, Dr. Villani was the lead NIH representative to the Healthy People Federal Interagency Work Group, where she oversaw and coordinated NIH participation in the development of the Healthy People 2030 initiative. She earned her PhD in health services research from the University of Maryland, College Park, and her research foci include preventative medicine, substance use prevention, patient-provider communication, health literacy, and healthcare disparities. Thank you to our panelists for participating and serving on our panels today. I'm going to start us off with a brief presentation to recap on previous webinars and to set the stage for our discussion. So, to begin, we're going to focus on these following objectives in today's webinar, which includes recapping key elements of the HEAL public access and data sharing policy. We will be learning about the benefits of data sharing, gaining insights about the data sharing, gaining insights about data sharing from your HEAL program staff, and then gain an understanding of the nuances around data sharing. So let's begin with our recap. Why do I need to think about sharing data? Well, if you are a HEAL investigator, as part of your HEAL award, you are required to have a data management and sharing plan in compliance with the HEAL public access and data sharing policy. So this HEAL policy has two main elements, and very briefly, I'll walk you through them. And to remind folks on the call, these data management and sharing plans are typically 1 to 2 pages. So the first element deals with the HEAL investigators are expected to describe release of publication. So the how, what, why not. So HEAL investigators are expected to describe the immediate, how they will make their publications immediately available to the public, what methods on how the public and other researchers can find and access these publications, and if there are any anticipated limitations to the immediate and broad release of this publication. The other element has a couple more sub-elements underneath it. And it revolves around sharing of underlying primary data. So HEAL investigators are expected to describe the type of data that is expected to be generated by the research, as well as the type of data that will be shared. Who will have access to the data? When will the data be made available? And what methods the investigators are going to use to allow the public and other researchers to get access to the data, and if there are any anticipated limitations to broad sharing of their data. So that's just a recap on the HEAL policy. So one of the main reasons why HEAL investigators need to be thinking about data sharing. Another important recap, this is from our prior metadata webinar. What is metadata? This will be a topic of conversation that will be coming up. So we decided a brief recap may be helpful. So what is metadata? So for the purposes of today's discussion, it is data which provides information about HEAL data. More specifically, we define 3 levels of metadata: the level at study or data set, the level at variable, and the level at file. So each of these levels of metadata describe different information with respect to your data set. So study level metadata provides information about a HEAL of research study and our data set, versus variable level metadata provides information about specific variables that were measured within the research. And then file level metadata describes more specifically about the files resulting from a research study. An example might be DICOM file format. All right, now for the moment you've all been waiting for. We will now be having our panel discussion with the HEAL program staff on demystifying common data sharing myths. And so I will now invite our panelists to join us. I'll ask them to turn on their cameras as I stop sharing my screen. And then after we go through our moderated panel, I will then open the floor up for Q&A conversation. So I will stop sharing my screen. All of our panelists have just turned on their cameras. Let's begin. So the way this is going to be formatted is I'm going to make a statement of something that we've either heard from HEAL investigators or questions that were asked by HEAL investigators in either prior webinars or workshops. So the first one is, secondary analysis doesn't apply to me. Shelley, would you care to respond to this comment?
Yeah, so in the age of big data analyses and machine learning, we have a really rich opportunity to access invaluable data through the HEAL initiative and through the data sharing policy set forth by HEAL. And so secondary data analyses allow lots of new opportunities for exploration and discovery. So for example, secondary outcomes that might be of importance to your particular project, if you can find another study that uses the same study population and also probe the same variables, you might now be powered to effectively look at that particular variable in your study population. And so it affords you the opportunity to make scientific discoveries without having to rerun a clinical trial or additional studies to answer that question. And then the second thing is, science is always evolving, as we know, and so we can't predict what will be important in the future. And so having these data sets archived and easily accessible will allow us to go back in time and see if we can explore some of these relationships that might be of importance to your particular population.
Thanks, Shelley. That's a very compelling argument, both from a cost perspective and from a future-sighted perspective. So another statement that we've heard is an investigator might say, if people want my data, then they can ask me for it directly. It doesn't need to be accessible through a repository or through any kind of centralized HEAL platform. Let's see, let's have Wendy respond to this one.
Sure thing. So it's a common question that we hear, and there's a couple of issues here. One is the fact that not everyone knows you have your data. So being able to have it in a repository where people can find it is a really important aspect of sharing this data, so that we can actually have investigators be able to find all of the data that might have the variables that they'd be looking for. The other thing is, at some point, your grant funding is going to run out. And I know when I had my own data sets and several years later, people would ask me, oh, can I have that data set? Well, my statistician's gone or my data manager's gone, and now I have to go back and find the data set and find the data dictionary. And it's a huge pain, and I'm no longer funded on that project to be able to do it. So it's really challenging as an individual investigator to maintain all of our data sets. And so putting them into a long-term storage solution like a repository really transitions that long-term storage and all of those records needed to describe what the data is, the metadata that we talked about that Kira mentioned, are already in place for those repositories. So you don't have to find that person and ask them, why did we, convert that variable, or what did we transform there? It would all be in the materials that go into the repository when you submit the data set. So I think those are the big two reasons.
Does anyone else want to comment? Anyone disagree with what Wendy said?
Actually, if I could just add that one of the advantages when you put your data into a repository like that is it actually makes it discoverable for data systems that actually are looking for these things. And a lot of times the repositories also have they will have ways to actually know the provenance, sort of know that this data is actually associated with you or your lab. So it's not as if you're sort of putting it out there for the world and everybody's going to get to use it and you're not going to get any credit. So that's something that you can be looking for, is to make sure that there is going to be a DOI or something that's associated with the data that you're actually providing. And so then when data systems are used and are probing these repositories, they are able to actually discover those data and find the data. So this is something that isn't going to happen at all if you're not actually sharing it in a repository, if you're planning to just email it to people whenever they ask you about it. So I just wanted to add that as well.
Excellent point. So the next comment or statement is something that I personally was very scared about during my own research career. If I share my data, I will get scooped. Jen, would you like to comment?
Sure. Yeah, no, that is a common concern and a valid one, because you've just collected these data and now you want to hold on to them. You want to do your analyses. You want to finish that. You want to publish, right? And so it's completely acceptable to go ahead and set an embargo period for those data until you're ready to have them go live. At least by putting it there in the repository with that embargo period, you're letting people know that it exists and it's coming, but you still get your opportunity to finish your analyses and publish your findings on using these data. So.
Okay, an embargo period. What about Michael? Do you have any comments?
Sure. This idea of being scooped is really important, and we understand that your career advancement will allow your research to have a bigger platform, et cetera. So we're very cognizant of that, and those of us on the NIH side and those of us who are very interested in sharing data know that this whole sharing ecosystem is only going to work if people benefit. The people sharing the data will benefit from it in some way. But this idea of all the data that you gathered for your publication, so it's the data that's the underlying data for your publications, and those figures that you have in those publications is really the core data sharing requirement inside the HEAL initiative. So if that publication is already out there, you've already gotten that credit for it. So if you're now, sharing this data can only generate more publications from it. So that's one point I want to make. And the second point I want to make is you do have data sitting in a drawer, sitting on a disk, sitting in a notebook somewhere that could really benefit somebody. And you know, it might not be big enough for a paper, but you might get a new collaboration out of it if you make that available. And it's, you know, in that case, you're not going to be looking at it being scooped. You just gained a new collaborator. So that's another potential.
Personally, I do have a memory of walking into my undergraduate advisor's lab and him showing me a data set that was older than I was. So I highly encourage folks to consider what dusty data sets may be hiding away in their hard drives or their drawers. All right. So for many investigators, this is an interesting requirement that HEAL is stipulating, that they need to make sure that their data is ready to be submitted into a repository so that it will be made shareable. So for many investigators, they think putting my data into a data repository fulfills all of my data sharing requirements. I'm done. Once it makes it into the data repository, I can check out. Christine, would you like to comment on this statement?
Sure. I mean, I guess I'll first say is that in order for the data to really be usable and understandable by others, it's going to have sort of the context around it. It needs to the other person who's actually looking at it needs to understand what the conditions were in which the data were collected. Obviously, the other piece of metadata that's going to be with it is you, that the data actually came from you. But really, in order to be able to make sense of the data, simply seeing, you know, numbers and having columns and rows and that's it is not going to be sufficient for somebody to actually be able to tell whether or not it's informative for when they are trying to integrate it with what they know from their own experiments. And I do want to add, even though it's not particularly speaking to the point of whether or not that fulfills the obligation, I do want to mention that, you know, when other people are using the data, it's very possible that they are not actually using it in the way that you had been using it, the way that you had envisioned. So, for example, if we think about a very specific example of where you were particularly focused on the regulation of a particular gene or of a particular network of genes, but in addition to capturing those data, you were capturing information on other genes. Somebody else who comes along may actually be interested in those other genes. And like Michael said, this would be an opportunity then for you to potentially have a new collaborator, you know, and somebody who's sort of tangentially related to or sort of adjacent to what it is that you're interested in. But again, in order for all of that to happen, they need to have enough context. They need to have that metadata that's associated with your data. So when you're providing the metadata, I think you want to keep in mind, like, am I giving enough information for somebody who's looking at this to be able to sort of make sense of the data and relate it to their own findings that they may actually have.
Michael, do you have anything you'd like to add?
Sure. I want to give a concrete example here that might really help people out in the HEAL space. So when it comes to reproducing animal models for translational research, does it work in this animal model? Can I use it as a go, no-go decision in bringing this therapeutic or the small molecule or biologic to the next stage of development? Is it worth going there? We see a tremendous amount of variability in the responses in one lab compared to another. So that metadata, that explanation of how the experiment was done, especially in the case of the control groups, where, you know, those ones that are getting vehicle injections, and the response to those animals, that's really a pre-competitive space. That's sharing those responses in those animals when another group is setting up that animal model can really inform them, am I seeing something similar to what others who have implemented this model are seeing? And is it now worth me testing out my intervention in this model so that I can, you know, rely on the data whether or not I should go or no go? That's just another example of how you can benefit from other people's control groups, and they can benefit from your control groups too in a pre-competitive space area, even with therapeutic development.
So the next statement is something that we've heard as part of the HEAL Stewardship Group. There isn't a suitable repository for my data. So for folks who are just now getting into the space and are listening into these webinars, I would like to give a shout out to some resources that the HEAL Data Stewardship Group has been building to support you. One of these resources includes a repository selection quiz. It is a very simple yes/no quiz that will give you some recommendations on repositories for you to consider. But if you find that those recommendations don't make sense for you, you are always welcome to reach out to the HEAL Data Stewardship Group, and we will be more than happy to meet with you and set up one-on-one conversation to figure out exactly what your needs are to best address and figure out what repository best works for you. All right, so this next statement is a little bit of a doozy. So let's say I store my qualitative data on my computer because I don't think data repositories or academic libraries can address the specific challenges of qualitative research data. Let's hear from Jen.
Sure. I am learning myself about qualitative data and data repositories. So I feel like Shelley would do a better job here, but I can kick us off from what I've learned recently. So, and I'll probably do more of a real world example as well, like Michael did. So with the healing community study, which is what I can speak very well about, we are collecting quite a bit of qualitative data, and we've been discussing how to really get this into a usable format because, you know, first things first, that these data need to be de-identified. And that was quite a process to de-identify when you're thinking of pages and pages of transcribed interviews would be one of the types of data that we will have in our study. That is quite a process to go through and de-identify all of those reams of data and then get it into a usable format. I might want to call on Shelley here because this is something that we're actually following probably her lead on as far as options for qualitative data. And there is one data repository that I'm aware of that is, you know, able to handle that.
Yeah, thanks, Jen. So I can sort of share my experiences that we've had through JCOIN, which is the Justice Community Opioid Innovation Network. It's another flagship HEAL initiative. And there's a lot of qualitative data that's being collected across these 13 individual projects within the JCOIN network. And so not that this is a NIH or HEAL endorsement of a particular repository, but we have come across a repository that will de-identify the data for you at Syracuse and also store and archive the data and have very controlled, secured access, granted permissions to researchers to access the qualitative data. And I think qualitative data and there's other types of data that are often overlooked when we talk about data sharing. It's very much quantitative data sets that we often think about. And I think that there is a lot of potential and power in de-identifying and reusing qualitative data, especially for longitudinal studies where we're evaluating policy shifts or changes in treatment or changes in payment. There's a lot of information that's stored in those qualitative interviews. And we also talk about reproducibility challenges with qualitative data sets as well. And so having your data archived in a way that de-identifies the participants and makes it HIPAA compliant can be a huge resource. And I think that the qualitative data is really emerging. It's in its infancy with regards to data sharing, but I think that we're getting smarter and better and more creative about how we share these types of data. And so I'm happy to share more information about this particular repository at Syracuse, but there are resources out there that will go through the challenges of de-identifying your data and storing it for future use as well.
So out of curiosity, a question for the entire panel. Have any of you ever encountered an investigator or an awardee who refused or was unconvinced that they needed to put their data into a repository? And if you have, were you able to sway them? What was your argument?
I can talk about that in the context of some engineering projects for device development. And there was a confusion when it came to the requirement for the underlying data for the figures or the publications that came out. So in the process of doing an engineering project, there's a tremendous amount of iteration that goes on. So the initial prototype and then small changes here, gathering more data, changing the device based on that data. So it goes through many, many iterations. So the PI kind of pushed back and said, you know, do you really want all of my data that I really use to develop this particular device to then make this figure? I'm just giving you, you know, hard drives full of information, of iterations that currently aren't here. And that's not really the goal here, though that might be useful information for somebody, and we do see that. But there's this cost benefit for the amount of data as opposed to the requirements for the HEAL initiative and what we imagine might be useful for others. So if we stick to that underlying data that you want to put forward because it makes the figure itself, you know, the data points there, and the lead up to that figure so that it's understandable about why you made those engineering choices, et cetera. So that once I explained it in that context, then there was just a tremendous amount of stress that went away from the interaction that we had with the PI, and they were able to comply.
That's a great point. If you're stressed about how to share your data, it's always good to seek clarification from program staff. All right, and speaking of clarification, so we have heard from an investigator before saying something along the lines of sharing my data means sharing my raw data, and I just can't do that. Let's hear from Wendy. What's your perspective on this?
Yeah, we hear this a lot in the PRISM program, which is Pragmatic and Implementation Studies that uses electronic health records, because a lot of our investigators have access to a whole lot of data, much of which they don't use. And certainly they don't have permissions to share people's entire electronic health records through these different formats. So we always talk to them about, well, what's the data you're actually going to use for your analyses to be able to test your aims and what you said you were going to test. And that's a really important element. But another important element of this is what was in your consent form? What did you tell patients you were going to share? Which is why you should be thinking about data sharing as you're designing and writing your consent forms when it comes to human subjects types of studies. But also, there are things that are going to have to be removed from especially human subjects data sets that might include identifiable information. And so you may collect one variable that would very much identify an individual, but that might be used to get a whole lot of other information. So you might be able to get socioeconomic information or social determinants of health information from something that might be identifiable, where you can't share the identifiable variable, but you can share all of these other ones that give more context and more richness to the data and allow you to look at different predictors of outcomes or different confounders of outcomes that can be really important. And so, you know, again, it's down, you know, Michael, what you were talking about, sharing the data that is really about the paper and the analyses that you do, as well as any other data that you've collected for research purposes, as opposed to sharing all of the data in our studies that might be part of the electronic health record that you have access to, but that weren't really used for research purposes.
That is a really helpful. Oh yeah, go ahead, Shelley.
Sorry, I just wanted to sort of add on to Wendy, because I think it's really helpful to give a concrete example where you don't share the identifiable data, but you share the associated information. Social determinants of health is a huge issue across all sectors of NIH, public health, policy, et cetera. And there are ways for you to share sort of community level demographic information about the economics, about transportation access, about housing instability that's associated with a particular area code. Now, you don't have to share the area code, you don't have to share the address of the particular participant, but you can share some of those socio-demographic characteristics of that individual's community. And I think that adds another level of enriched information without sharing the PII. And so I think that's like a really great example of how we can leverage sort of, I guess it's behind the door sharing without identifying the participant, but it really enriches the context in which the data were collected at that particular time point.
Thank you for that example. Jen, do you want to add any insights?
Yeah, I mean, so we have, I'll give another concrete example because it's a very different one from the one that was just shared, and it might be helpful as people think about their own situations. And again, I come back to the Healing Community Study, which very briefly is a very large implementation study within 67 communities. So the measures that we are monitoring from sort of an administrative data side would include things like number of opioid overdose deaths within a community. So we're getting aggregate counts across many communities, and we do plan to share aggregate counts. However, there are going to be things like data suppression rules that will impact us. And so I think we will talk about this a little bit later, but the data use agreements are very important in helping us decide what can be shared and what we simply cannot. And I will emphasize that there will definitely be cases where we just won't have a valuable, it'll be suppressed and in perpetuity, and so the repository will have some sort of note there that it was suppressed due to low numbers. So again, we're looking at aggregate counts in our study, and that will be not raw data as this example asked about, but we can provide what we can provide as it relates to both data suppression and data use agreements.
On a slightly different track. So there are a couple of investigators that we've talked to that are interested in making sure that their data has useful metadata for future research purposes, but they're concerned because they feel like they need a lot of time or additional resources in order to curate their data. Michael, what do you think about that?
So it's very common, not in the HEAL Initiative, but at the particular institutes, for there to be administrative cuts to the grants. That's pretty standard, not in all institutes, but in many institutes. For instance, at NINDS, for anything that's not a modular grant, there's a 17.5% cut, whatever budget was written in there. Inside in HEAL, there are none of these administrative cuts. And initially, our discussion that we had with the first set of funding announcements that went out for HEAL was that the proposed cuts that we would have done, we would hope that they would use those amounts of money to, through the duration of the project, prepare their data to be shared. Now with the most recent funding announcements that we've put out, our U19 for the initial therapeutics development ones, the human pain genes, they all have data aspects of the grants that are part of the review. And part of the review is who's going to be responsible for sharing that data. So it has to be built into the application on the front end. So hopefully the researchers at the time of their writing their application are asking the questions from themselves, what kind of staff, what kind of expertise do these individuals need to have in order to interact with some particular repository, to interact with the HEAL ecosystem to fulfill those data sharing requirements. The sooner the research community starts to understand that sharing data needs to be, discussed, talked about, and built into the budgets before the application comes in, then the sooner these particular types of questions will go away. That's the way I see it.
Michael, to ask a follow-up, if I am a researcher who has never curated my data to this extent or has never submitted my data into a repository, how am I supposed to figure out how much to budget for?
That's a great question. You know, inside many universities, you have, okay, let's talk about the basic scientists. Basic scientists typically don't do this. When it comes to clinical research, I think this is more common. So let's just talk about the basic science first. The basic scientists need to reach out to those statisticians and to those data scientists at their university, and they're there, right? And those people, at least some of them, will have experience maybe working with some of the clinical groups and doing this type of work. Maybe some of the people in those offices are already the people you're responsible for doing that for multiple projects at the university. So many universities have that resource. If that doesn't exist, reach out to the program staff and ask us, and we can help you. We're not going to write your budget for you, right? But we can give you a hint of how many, that's right, how many people are required, or a percentage of a person's time, and what kind of expertise, what kind of background should they have, and the type of projects they should have worked on beforehand. So when that does come to review, it'll review well, and the budget will be reasonable. So reach out to us if you don't know.
Thank you. That's good to know.
Kara, can I just add,
yeah.
I don't know if we've actually brought this up, but NIH has a new data sharing policy that will take effect for applications coming in as of January 2023. And budgeting for data sharing is an element that's going to be covered in all of those materials. So I encourage you to take a look at that new policy, and it's currently in place for HEAL, and we have a HEAL data sharing policy, which is on the HEAL website that I think you referred to, but this is going to become the norm for all of NIH. So this is, you know, we're getting you in advance prepared for what's to come for everything else. So, you know, there's lots of resources and lots of information coming out and already available about how to build these types of plans and how to budget for those.
Excellent point. Thank you, Wendy. All right. We're beginning to run low on our allotted time for the panel discussion, so I'll make one or two more statements, and then we'll start opening the floor to live Q&A. So Jen, you alluded to this earlier. So certain investigators have made a statement to the effect of, my data use agreements don't allow me to share data.
Yeah, that very well may be the case. I can again speak to the Healing Community Study, which was one of the first HEAL projects to really get funded and get moving early in 2019, and that certainly was the case. Many of the data use agreements that we initially put into place do not mention data sharing and data repository. So what we're doing now, I mean, we have about, I would say, over 30 data use agreements in place with various partners. So what we're doing now is we're going back to those data owners and having conversations with them about the importance of the data repository sort of part of this study, and trying to address any concerns they may have as data owners, and trying to explain the you know, how we can mitigate those concerns, but also how valuable these data can be to others, just as my colleagues have described, you know, earlier in this hour. So, you know, even though your data use agreement right now may say it's not allowed, it doesn't mean it's set in stone. It can be revisited, and that's what we're finding we are able to do. And in many cases, as we just alluded to, the NIH grant requirements are moving in this direction where it's a required part of grant funding. So, you know, but I agree, there still may be cases where your data owner, especially speaking of administrative data, may have a very legitimate reason and will not budge. And so there may be instances where you cannot share a certain set of data. Absolutely.
I think another common example of this, Kara, is if we have investigators that are using Medicare data, they sign a data use agreement to use the existing Medicare data, and would need to be very careful in what's in that agreement and what they can and cannot share. And talking with our colleagues at CMS about whether those final analytic data sets could potentially be shared, because they have been de-identified as opposed to the full data set that they had access to in order to do their initial analyses.
Thank you for that very specific example. So I'm going to make one more statement to give folks time to put in their questions into the Q&A box. This statement, I think, Michael, you're probably going to be the best one to respond to this. It's difficult to share data that is linked to intellectual property or proprietary data.
I can start with an answer to this. As I mentioned earlier, to any of these projects that will be generating the IP that the university or a company that's funded by the HEAL Initiative wants to protect, we totally understand that, and that's what drives these products, meaning therapeutics, getting to the market. We totally get that. But in the process of doing these experiments, there's usually data that's in the pre-competitive space. Again, testing out these animal models with positive and negative controls, ones that have been tested by other groups and your vehicle, et cetera. That's pre-competitive data. Decisions that you make in the process of bringing the therapeutic forward and making those go and no-go decisions, maybe those no-go decisions could be communicated to other groups in order to have them not have to reproduce those avenues or those questions and research that led to you to make a no-go decision. Maybe this isn't a good target, right? Because of your experience with XYZ model and getting it into the patients in your phase 2 clinical trial and having that data. So the goal here of the HEAL Initiative in the context of enhancing pain management is really one I think we all agree is going to require collaboration and some sort of sharing. So sharing those decisions so that other groups can focus their resources, either federal funds or their private funds, in their therapeutic development in the right directions and not reproducing, failed areas, I think will help us get to that goal.
Anyone else care to comment on this before we begin diving into the Q&A? All right. Okay. We have, oh boy, lots of questions for the panel. All right. First question. In regards to data access, what about when the data is accessed via a data use agreement from another party? For example, when the data comes from the state or a commercial third party?
Can you repeat the question? That was,
yes,
I don't know if I understood it.
In regards to data access, what about when the data is accessed via a data use agreement from another party? For example, when the data comes from the state or a commercial third party?
I can try and take a stab at this, but Wendy, you unmuted, so maybe you have more profound insights than what I might offer.
Well, I was going to say that I think Medicare is an example of this. And I think, Jennifer, I think what you were saying about having a discussion and trying to negotiate your data use agreement, which is harder to do with a commercial, with something like Medicare, where it's a very standard format. I think those types of things, we may want to talk directly with our CMS colleagues or others about how to do that. But I think negotiating and saying that, part of this initiative is to have a sharing of data, and that it wouldn't be the entire data set that you get access to, but maybe the data set that you use for your analysis. And could that be shared if it's de-identified and stripped down to not include any identifiable information, would be something. But I do think that you're going to have to describe what you can and what you cannot share, knowing that the whole goal is to move science forward. And the more you share your data, the more, like Michael was saying, we prevent people from doing the same experiments and not getting any results again and again. We want to move the field and keep things going. But Shelley, what were you thinking about adding to that?
I think just to sort of reiterate that the type of data sharing depends on where the data comes from and who owns it, right? So I can think of a very specific example within JCoin where 2 of our projects are using administrative data sets that are being conducted by the states in which the studies are occurring and doing policy evaluations. And they will not share the data with us, but I still think that there's powerful questions that could be answered in those projects. So we certainly wouldn't want intense data sharing to prohibit execution of the study, but we would encourage you to be creative about data sharing where it's possible. But, you know, I think CMS is a great example where there are extreme limitations on what you can and cannot share and what you can and cannot publish on. And so we have to play within those rules. But there are sort of creative solutions that come up with CMS in particular, but that's just two examples of data where, you know, it's not being owned by the researchers. And then there's this other issue of sensitive or vulnerable populations and what types of data do you share about those individuals, especially among tribal communities, which have brokered their own set of rules with federal agencies about data sharing. And I'm not an expert in that domain, but that's another example of where extreme limitations on data sharing can occur, but you don't want that to prohibit the successful execution of the study.
Thank you, Wendy and Shelley. All right. So to the point of data reuse and credit, can the panelists please comment on the practice of data citation?
I can address that a bit. When somebody cites someone else's data, they have to identify who that author was. Maybe it was from another publication and it was the underlying data for another, you know, publication, so that you can cite the publication, identify the author there, identify the electronic location where it was retrieved from. Sometimes that's a DOI, the digital object identifier. Sometimes it's a URL, those web addresses that we're familiar with, and then maybe some information about how to find it inside a particular repository. So you can cite the repository also. So that can be done in the methods section. It can be done in the discussion session. And even in the case of the publications, obviously, that's going to end up in the literature cited section of your paper. So it can be put in those individual area or multiple areas of the paper. And the point here is that if the community starts doing this and it becomes commonplace to see it, we'll have more people sharing their data and then more people using it and then more bang for the buck.
I'll give a couple of seconds for anyone else who wants to respond. Okay, next question. Do you have any advice on addressing data sharing at the application stage? So the person who asked this question is referring specifically to an RFA 22-044.
I would say first, for a very specific HEAL RFA, you should always contact the program officer that is involved, because they are going to have this long vision plan for what data sharing and other elements of that particular program looks like. I can speak a little bit more broadly to other programs, and this, you know, I think Michael hit on this a little bit earlier, where we're talking about appropriate budgeting and things like that. So I think the question is depends. It depends. If you're funded by HEAL, you have to comply with the data sharing policy. I think everyone knows that by now, hopefully. And so the nuanced response is, you know, it depends on what type of program you're applying to. If you're applying to a large coordinated network where things like common data elements are being created and harmonized, the level of effort of data sharing and specifics around that would have to be greater detailed in the application. HEAL does have a number of programs that are just sort of individual projects centralized on a particular topic. And so the coordination or the harmonization amongst projects may not be there. Now, you may choose to align your particular application with an existing network in hopes that you can kind of be folded in, or at least benefit for some of the data that's being collected in real time, in which case those data sharing practices would have to be given more thought. So I think at bare minimum, you share your data when the publications are out. But the level of detail of data sharing that's required, it's going to depend on if you're going to be a part of this very large network or not. And your program officer will definitely know the answer to that question.
Yeah, that seems to be a central theme. The HEAL program staff are here to address any questions or concerns or provide clarifications as needed. Next question. If data can be de-identified in accordance with HIPAA definitions, why does a data use agreement need to specifically mention sharing data?
So I think I can maybe try to tease this one apart a little bit. So if we're talking about HIPAA, we're talking about human subjects data. And so I think it's more at the stage of, so if you're getting a HIPAA authorization from an individual, that means you're probably consenting an individual as well. And so it's actually the consent form that needs to describe what it is you're planning to do with the data and whether you're going to be sharing it or not, so that the individuals participating in the study can agree to the fact that you're going to be sharing their data in the way that you're planning to do so. Data use agreements tend to come into play if you're using data that somebody else has already collected. Then you sign a data use agreement of how you're going to use that data and what you're going to do with it as an investigator once you have access to it, and how you analyze that data, how you're going to work with it, and whether you can or cannot share it with others is part of that data use agreement. As an investigator in HEAL, if you are collecting data like human subjects data, and then you put your study data into one of these repositories, some of those repositories will require future individuals who want to use that data to work through and do their own data use agreements to use your data in the future. So it gets a little complicated depending on what stage you're at, but I think I hit all of those elements right. But please, you guys, correct me if I got any of those out of order in terms of when you might see a data use agreement or be dealing with consent or sharing issues.
I would just add, it depends on where you are in the process, right? Like if the data are published, it's going out, everyone's going to see it. But there's at least 2 networks, probably actually more, I can think of 4 within HEAL, where data sharing is occurring prior to publication. And that benefits the network. Again, when we talk about secondary data analyses or powering for secondary outcomes, being a part of a network would afford you to answer some of those additional questions that may not have been the primary targets of your application. And so having data use agreements set up before, when you're kind of in this gray area of data collection, but before publication, is really helpful to get the legal information down, make sure that you're being honest with the participants, and also furthering the benefits of scientific data sharing so that you can answer some of these questions collectively as a network. So I think when you're in that gray space, DUAs are very helpful. Burdensome to execute, but very helpful to have in place.
So we have a follow-up question for data use agreements. So for data use agreements, do we use the template from the repository where our data will go, or does each HEAL study have specific requirements? And which one would take precedence?
Some HEAL programs, as Shelley mentioned, don't have specific formats for the data. If we're supporting R01s in a specific space that are just, open-ended. But if you're part of a network, so let's start with the common data elements for that network, and then how to fit those requirements into the requirement for the repository. Some of those repositories are going to be maintained by a data coordinating center in some of our networks inside HEAL. So that's, relatively straightforward and easy. And some of them will you be using, public repositories, et cetera. There's a balance for the two, and we're just asking you to share your data in the most, usable format possible with fulfilling all your requirements for HEAL and to the repository and to the, the granting mechanism itself. So, you work it out, work with your program staff, work with the staff at your university. There is a pathway to do this where everybody benefits.
Next question. Are there standards for repositories, i.e. with Dataverse work, for organizations that want to stand up local infrastructure? And if they do that, is there an index of those resources?
I don't have an answer for that.
That might be a Renzi answer.
Yeah, I was about to say, I think this feels like I should be All right, I'll call on myself to answer this. So there are a number of repositories that have been vetted by NIH HEAL program staff that after doing a preliminary analysis on the studies that are being done within the HEAL initiative, and by the way, we are up to around 900 funded studies. But a preliminary analysis reveals that there are, somewhere between 20 and 30 repositories that may be able to house the majority of these data. So there are specific vetted repositories that we would recommend that you take a look at before going for local infrastructure. So as part of an email that will be sent out to all registrants, we'll include a link to these resources. So if you are curious and want to investigate what repositories we're referring to, you'll be able to explore more in these resources. Oh, Shelley, would Shelley please provide URL or the name of the repository for the qualitative data?
I can put that in the chat, and actually another attendee had shared that, so I'll just copy it and put it over.
Kira, do you want to mention, I think I've heard your team present a little bit about sort of how you came up with some of the the key elements that you were looking for in the repositories. And I thought one of the things that was really helpful for investigators to think about is sort of how likely is that repository going to be there in the long term? You know, if you're going to go through all the work to put your data somewhere, you want them to be around for a very long time so that they don't, disappear and then your data is gone too. I mean, hopefully that doesn't happen and things get transferred to other places, but I think, I don't know if the materials that you're going to send around have a list of those sort of key elements that you guys looked for.
Yes, actually. In fact, as you were asking me this question, I went to the healdatafair.org website to look up the specific resource because I can't remember off the top of my head. But we did, the HEAL stewards did have specific repository selection considerations. Mainly, we wanted to be in alignment with what NIH viewed as best practices for repositories. But these criteria include persistence. So as a repository, is it going to be reliably present and maintained for a long term? So we're looking for 10 years or more. Is the repository fair alignment? So are they utilizing strategies to make data more findable, accessible, interoperable, and reusable? Is it suitability for study data? Takes into account the broad diversity of HEAL initiative study data. So we consider the type of studies, including clinical trials, preclinical, basic research, the various subject types, which include both human and non-human, and importantly, the type of data being generated. So there are over 20 different types of data being generated within HEAL. So we wanted to ensure that we had sort of like a core group of repositories that would be best suitable for the data. And then other considerations we had included data governance, if there were any sort of costs associated with the repository, because we wanted to make sure it was not going to be prohibitive for investigators. And then if there were future expansion plans for that particular repository, that sort of goes along with that repository will be more sustainable and hang around for the future. All right, so it is now at 2 o'clock. I apologize to the folks who still have lingering questions, but I want to be cognizant of everybody's time. And so I will move to close. Hopefully that shared the right screen. Yes, okay. So thank you all who participated in this webinar today. I just want to say to our panelists, Christine, Michael, Wendy, Shelley, and Jen, this was incredible. You guys offered extremely useful insights into sharing HEAL data. For the audience, we hope that you're leaving with a better understanding of the nuances of data sharing, why data sharing is important, and the impact of data sharing. And hopefully you're also leaving with an increased motivation to share your data among the HEAL community. In addition to a recording of this webinar, we will also email anyone who has registered for this event a list of resources that will assist you as you participate more deeply in the HEAL ecosystem. This slide deck will be shared, and a link to our Slack channel and Connect with Us forum will be located in the chat box, but will also be included in the email. We hope that you will reach out to us, the HEAL stewards, for questions or support as you embark on your FAIR journey to maximize the value of HEAL data. And finally, we hope you will save the date for our next webinar on March 17th from 1 to 2 p.m. Eastern Time. We will be joined by Andrea Tentner of the HEAL platform team for a presentation and discussion around metadata as an extension of our previous Metadata 101 webinar. So if you have questions around metadata, or if you're curious about what the core recommendations for metadata will look like for HEAL, I highly encourage you to join in on this webinar. Have a wonderful afternoon, everyone. See you next time.